It's my pleasure to welcome everybody tonight too. My name is Lynn Erdman, and I am the Executive Director for Carolina Breast Friends, which is really what I would call a dream job. This is a wonderful place to work, and I'm honored to be part of Carolina Breast Friends. Many of you on here know Dr. Turk, I know, and some of you may not, but you're in for a treat tonight. He is a general surgeon here in Charlotte with a subspecialty, of course, in surgical oncology, but he's also the medical director of surgical oncology for Novant Health here in Charlotte. And he's also a clinical assistant professor at the University of North Carolina, Chapel Hill. So we are more than honored to have him. I can tell you he's also a good surgeon. I've actually used him several times. So from the patient side of things, A+. So thank you so much for being with us tonight and for sharing your insight on the history of breast cancer. And I will turn it over to you, Dr. Turk.
Good. Thank you, Lynn, and thank you, Leslie. This hopefully is fun, and I'll keep an eye on the time. So let me share my screen. There we go. All right, is that working? Good. And can you hear me? Good. The computers are not my friend usually. So again, Lynn already did my my initial slide, but the history of breast cancer, I've not done this talk before, so there are some new slides. I've done the history of cancer, which has always fascinated me, but this we're able to focus specifically on breast cancer. And it is from Halstead's first surgeries to what we're doing now with a lot of targeted therapies, but also mixing in some interesting vignettes in between time. Let's see if I can. Next slide. There we go. I can do the next slide. So what I'd like to do is just review understanding cancer as a disease and its care, how we've moved forward in our management of it, specifically breast cancer, looking at the history of surgery, the history of radiation, and then looking at not just treating the breast, but looking at the whole body as far as how we started with chemotherapy, how did we get started with hormone therapy, and what the new immunotherapy or the targeted therapies are all about. And finally, just to loop it around, not just treatment of cancer, but treatment of the cancer patient as well. I have to focus on, and we have to be done by 7 because we have a big show coming tonight at Masked Singer, so I don't want to miss that, so we'll keep my focus going. Just a starting point, culturally, St. Agatha is the patron saint of breast cancer patients. In 231 in Sicily, she was martyred for her faith, and supposedly she had her breast taken off by pincers. Just a terrible event, but if you have to have a patron saint for this, she is a good one. So interesting history of what the perspectives was of this disease process. We're just going over the impact of cancer itself. Taking all cancers together, 33% or a third of women will get cancer at some time in their lifetimes. 25% of women will die of cancer. And by the end of the 21st century, cancer will be the #1 killer. Will overtake heart disease as the #1 killer in the world. We sure have a perspective on breast cancer. The perceived lifetime risk of developing breast cancer is in the 30s to 40%. In the reality, it's about 12% risk of developing breast cancer. So it's not as bad as it seems, but we sure seem, as we've gotten older, more and more people getting it, more friends get it. But we'll look at those statistics. And is it really increasing? And where are we standing on incidence and survival? Go all the way back, 1600 BC. This is from the Edwin Smith Papyrus. 1600 BC, there was description in the in the Egyptian literature of breast cancer, where they weren't sure exactly what it was, but they realized that it was not curable. It was treated with cautery. It was a miserable event back then, and it was then the next step was Hippocrates, who was the father of medicine. He's the one who coined the phrase of carcinoma. It's a Greek word for crab. Cancer looks like a crab under the microscope and the way it attaches to other tissues. And for oncology, he coined the word onkos, was a mass or a burden. And he actually documented the stages of breast cancer. So fascinating study that he had. And his answer to what we do with breast cancer is it's best left untreated because the patients live longer that way. And the next person who
Okay, Monday, yeah. So have a good week.
course of breast cancer care was Galen.
Don't
Galen's
get in no
cancer is
trouble.
caused by an excess of black bile. So he thought
Bye, honey.
everything in our body is based on black bile, green bile, red bile, and white bile. And he thought, well, purging and bleeding will help cure the disease. So I think go back to Hippocrates. I think Hippocrates was right. Forget the bleeding and purging. At that point, is best left untreated. And his views were unchallenged for until about the 1500s. There was mastectomies discussed in 548. Obviously, a whole different kind of treatment than it is now, but it was treated surgically way back then. So what causes cancer? That's been a question all along since we first identified it. And a great quote from 1914, Dr. Wood said, "We have learned nothing, therefore, about the real cause of cancer or its actual nature. We are where the Greeks were." Go back to where Hippocrates was. 1914, they really didn't know. To take a step forward, about that same time, there was Percival Potts, was a epidemiologist. He noticed that little chimney sweeps got scrotal cancer. How does this relate? Well, think of Mary Poppins, the little chimney sweeps. These were 5 or 7-year-old boys because they were small. They were put down the chimneys to clean the chimneys, and they never cleaned up. And it was the coal tar that caused the cancers. And he worked to force the government to stop allowing these poor boys to become coal sweeps, and the cancers disappeared. So from that, someone said, well, maybe coal tar causes cancer. So they actually proved it in 1915. You can cause a cancer by irritant. And since then, occupational hazards we realized cause cancer. The radium girls was such a sad story of the girls that painted the fluorescent dials on old watches. Of course, the dials were very small. They used very fine pointed paint brushes. And to make the fine points, they licked the paint brushes and then put the radium on it. And they died of terrible head and neck and mouth cancers. Benzenes, they realized, causes the bladder cancer, asbestos for lung cancer. Even in the 1950s, they talked about lung cancer and the correlation with smoking, but it took 20 more years for the actual Surgeons General to make the recommendation to stop smoking. Finally, we get a clear answer. Mary Claire King, 1992, identified the BRCA1 and BRCA2 genetics. And this is a little timeline of the genetics of breast cancer. 1866, Dr. Broca described familial cancer. He said there are families that have a lot of breast cancer. And you pop into it, you realize in the 1970s, the new studies prove that ovarian and breast cancer are somehow linked. And Mary Claire King in Nebraska said at Creighton, decided she needed to look for the genetic correlate. And in 1988, she published the inheritance pattern. And go back over to 1991, she coined the name BRCA1, and 1994, BRCA2. Those were huge changes. And even 2 years later, Myriad Genetics, you may have heard of Myriad, they offered the first BRCA1 and BRCA2 genetic testing. It was very expensive, and it was not available to very many patients. And we'll talk about this. Now it's really changed. The Human Genome Project was able to identify all the sequencing, and now genetic testing is absolutely available to a majority of patients that want it, because it's gone from $3,000 when Myriad charged to $300 per patient now. And insurance companies are much more amenable to allowing patients to get genetic testing. So this is what a genetic test looks at. Look at the bottom row. These are all the genes we're looking at now. It has just boomed. Genetic counseling is a great profession at this point in time, because you see that I had a patient today with CHEK2 breast cancer, and BRCA1, BRCA2, but all these others that we really don't know, all of them, what their genetic risk of breast cancer is. So TP53, there's Pancreas Cancer Association. A lot of these have renal cell cancer associations. So these are all the tests that they put you through when you go through panel testing. You look at the first circle up on the left. Overall, it's about 12, 15% that are positive, most genetic testing is negative. And of those that are positive, BRCA1, BRCA2 is the most common. And so it is a much more common to get genetic testing now. Fortunately, majority of people are negative. There's a lot of variants of uncertain significance called VUS. There's a variance of the normal genetic pattern, but they don't know whether it has any correlate. And they're going to follow those in the future to see if they pan out to be another genetic problem. But genetic testing has been huge, and it's really just starting now. So in the future, it will look completely different and give us much better answers than we have now. So the cause of cancer, genetics is a big component of it. You look at hereditary, that's what we mentioned, hereditary breast cancer, 5 to 10%. If we look at the genetics, it's not a big amount, but those patients have a tremendous risk, 60 to 90%, that's in the red, of getting breast cancer. A larger amount have familial. They don't have a defined gene, but we know that there's some genetics in there somewhere. They have a little increased risk, but not profound. But the majority of breast cancers are sporadic, which means they're not related to genetic risk. They just happen because you're a female, and as you age, the increase goes up. So majority of cancers are sporadic and unrelated to genetics. Other risk factors, we look at inherited mutations. We just talked about that. Radiation, that was a more recent event. In the past, in the 60s, 70s, and early 80s, they were treating Hodgkin's disease with radiation. They didn't have good chemotherapy for it. And these young girls, prepubescent or teenage girls, would get chest radiation to cure the Hodgkin's disease. But then we realized 20, 30 years later, they are going to get breast cancer. So we realized radiation itself can cause breast cancer. We have a lot of contributing factors that we know of, excess alcohol, exercise. A lot of these we're going to clarify better as we go on. Vulnerabilities means what puts you at higher risk? Well, early onset of menses, late menopause, more exposure to estrogens, and no pregnancies. But again, those are limited. Those are not a large factor. That in itself will not cause breast cancer. So it's a whole combination of things. So that's the cause of cancer, specifically cause of breast cancer. We don't have all the answers, but we're moving toward that, and we're going to use that to our best avail in the future. So I want to look at the treatments of breast cancer, split them up into local treatment of the breast, which is surgery and radiation, and then later go into systemic therapy, trying to prevent it from coming back elsewhere. That's the chemotherapy, the hormone therapy, and more recently, the targeted therapy. So we'll go through their histories. And to me, it's been fascinating to watch this. I've been in practice 25 years and seen a lot of these changes. And it's been exciting to do a lot of the research on this as well. So the local treatment, and this is just a first overview, the evolution of breast cancer treatment, radical mastectomy, they were doing big mastectomies even before that, but this is when it became a science, and I'll explain that. And then in the 1930s, they realized, oh, we can add radiation to those at-risk patients. Radiation will kill the cancer in the chest wall. It may not improve survival, but it does help control the disease in that area. Like other things we've done with surgery, if some is good, more is better. I'll describe a little bit the ultra radical mastectomy. It's as bad as it sounds. They get, if taking out the breast is good, why not take some chest wall with you? So fortunately, that is passé by a long shot. And the initiation of change of looking at breast conservation, that started with mammograms. And then we have research trials showing that breast conservation or lumpectomy works just as well. And then we've improved the patient's status. The last couple, the sentinel lymph node biopsy, so we don't have to take a lot of lymph nodes out because we're catching these cancers earlier. And then new reconstructive techniques that have veered some patients away from breast conservation and toward more extirpative, more preventative surgery. And we'll talk about those. Let's go back. This is it. This is surgery. A chance to cut is a chance to cure, heal with steel. Look at that barbaric event there. So it is the first mastectomies. You can imagine what that looks like. It was just, it's a way to cut right across. It's like cutting wheat. But it's all they had back then. You can imagine how excruciatingly painful it was. They have no antibiotics, they have no anesthesia, and it is miserable. So healing with steel has come a long way. This is one of my favorite surgeons. He was really the father of surgery. He was French. He was a barber surgeon. Well, you have to remember, what did surgeons do back then? Probably the safest thing they did was cut your hair, but they also would cut your leg off or your hand off if you needed it. There was not a lot of invasive things going on with surgeons back then. And his adage was, I bandaged him and God healed him. That's the science they had back then. I think sometimes I know it's true that God does a lot of the healing. It was just quite a phrase that he used. But he introduced, rather than say an amputation, which was typical surgery, they'd cut it off and try to stop the bleeding. They'd put a hot iron on it and burn it. Poor patient, if he's not in pain enough with just having it cut off, he was able to realize that we can put sutures or put ties on these arteries instead of having to burn everything. So he was a blessed improvement to medicine. The next step was anesthesia. What a great change. It's 1846 in the ether dome at Mass General Hospital. Dr. William Morton, who is a dentist, used ether and proved that you can operate on a patient safely with them asleep without pain. And it was a huge change of surgery. Again, no IVs, no antibiotics, but at least the patients don't feel as you work through it. You can look at that. This is surgery back then. No surgical gowns, no gloves, no masks, a lot of audience. You look at, this is called the ether dome, and you can still see it today. It's if you look at the front of Mass General Hospital, turn right, it's the old hospital, and you can see this, and you can walk in and see where history was made. So it's a great little trip, and they have a nice museum near there as well. So getting into modern surgery, the father of modern surgery, William Halsted. Again, he was the one we talked about, called the Halsted mastectomy. What did he do? Is it pretty phenomenal? He began the first modern surgical residency. Several years, you start as an intern, you process through to the point where you're functional and competent when you leave. He was one of the first to use temperature charts on medical records, realizing that temperatures are one of the first views that you have of how patients doing and any concerns that could occur. He was one of the first to employ emergency blood transfusions. It was on his sister. And one of the first to take gallstones out. It was on his mother. So I think his family was starting to get nervous around him, but a very bold man and obviously very sure of himself if you can operate on your own family like that. He was the first to use local anesthesia, regional anesthesia, rather than having the ether to put the patient all the way asleep. He realized you can numb people up. He was a very good researcher. Unfortunately, he became addicted to cocaine because of it. He was experimenting on himself. He was functional, but really debilitated in the rest of his life. And he was first to use rubber gloves in surgery. Why is that? Because Caroline, his scrub nurse, got rashes with the soaps, and he was able to invent the use of rubber gloves. Caroline became his wife later, by the way. And her maiden name was Hampton. And if you know, up in the mountains, High Hamptons in Western North Carolina, it's a resort, but that is their old homestead. That's where they would spend the summers. So an interesting history that he had. He would go from Baltimore at Johns Hopkins in the summer to come up to the Carolinas for cooler weather in Cashers. This was his results of his mastectomies. This again, look at the operating room. Pretty unsterile, no antibiotics. You just hope for the best. But he reported on 50 patients. Doesn't sound very good, but he had a low 3-year recurrence, chest wall recurrence rate, phenomenally better than anybody else at the time. No surgical deaths. Nobody else was able to define that. And he had a 5-year survival rate of 40%. But just remember what we're dealing with here. These are women with fungating, bleeding masses stuck to their chest wall. And he was able to make some great successes. So these were great successes at the time compared to what anybody else could do. But you realize what they did. This is taking off the breast. This is a picture of what they did at the time. They took the chest all the way down to the ribs. You take all the muscles off, you take all the lymph nodes off, and you leave an open wound to let it heal over time just by granulation. It was miserable. As you can imagine, every patient had arm swelling or lymphedema. They had decreased range of motion. They had chronic pain. It was a very difficult cure in those patients at that time, but it was a very difficult cancer. It reminded me of a quote by William Shakespeare. It was Hamlet, when Claudius was talking to Rosencrantz and Guildenstern, they were planning to kill Hamlet. He said, diseases desperate grown by desperate appliance are relieved or not at all. Meaning, and that's what the old surgeons were. You're all in, you do a big operation because it's a desperate disease. And that was the mantra back then. And even in my training, it still was going on. We fortunately have made some changes since then. This is radical mastectomy is good, meaning you take all the muscles. Let's do more. Let's get into the lungs. Let's try to cure this thing by combining radical mastectomy with removal of the lymph nodes that are inside the chest wall and the rib cartilages and the rib muscles. And it was just miserable. And so it did not last long, fortunately. So surgery became more extensive because we had good anesthesia then. We had ability to get blood transfusions and antibiotics, but it was not the right answer because of this man. He proved that, no, we don't need to be radical. And his quote is, surgeons have been taught one thing, radical surgery saves lives. It was Bernie Fisher who changed their minds. What he did was, he said, no, breast cancer is a systemic disease at its origin, meaning you're not going to cure it by being more radical locally. We're worried about spread elsewhere. And he was the one who started what is called NSABP trials, national trials, randomizing trials. And it's fascinating. I tell patients this now, the real bravery these women had. At the 70s, he started this, and he was laughed at the meetings, but the women were willing to be researched on, meaning half the patients had a mastectomy, half the patients had a lumpectomy, and we have 40-year follow-ups. The survival is exactly the same. The women did not get to choose which surgery they had. They were willing to be guinea pigs for future women. So he was brave, the women were brave, but they proved that we do not have to be more radical, that we can get away with a lumpectomy with just as good a survival. And this is just one hospital's perspective. You look at what he accomplished. This is lumpectomies rather than mastectomies. Started, very rarely did women have lumpectomies, but look at 69, 1991, 1993, 1997. Within a matter of 5 to 10 years, a tremendous switch from 20% to 80% in that hospital went to lumpectomies. So it was one of the most radical changes in history of surgery that was allowed. It was adopted very quickly, fortunately, and for the benefit of women. The other thing that made a big difference at the time was mammography. 1969, you could find tumors this big rather than large and massively growing tumors. Back in the day, when it was only found when you could feel it, 5 centimeters or 2 inches was the average size of the cancer. At the start of mammography, the average size was 2 centimeters. Now the average size is 1 centimeter. Does it make a difference? Absolutely. Size matters in this. As you look at survival based on stage, and we'll show you this as the next slide, but this shows the incidence of clinical stages over time. You look at 1977, let's look at stage 1, which is early cancer, 2 centimeters or less. It was less than 10% of cancers were found at that early of a stage, less than 10%, less than 10%. 1990, more than 10% are early stage. Mammogram made a huge difference. And here it goes up, and we're at 60, 70% of patients are early stage cancers now. And it is women doing self-exam, doing mammograms, but early stage of cancer makes a huge difference. Well, what kind of difference? This is survival rates based on the stages. This is 10-year survival for breast cancer. This is stage 1, pretty darn good, 90%. Stage 2, well, it gets under 70% over time. Stage 3, this is old data, by the way. This was 10 years ago. Stage 3, you're down to below 50%. Stage 4, we're struggling for survival long-term. Again, we've improved since then, but the stage of the tumor makes a world of difference as far as survival. So the mammogram has made just such a benefit, allowing more breast conservation and definitely allowing better survival. The other thing that I was involved with this from early on. This was exciting. I said in the old days with big tumors, we used to take all the lymph nodes out. Then we said, do we really need to? Because the majority of women with small tumors don't need all the lymph nodes out. So we did the research, injecting radioactivity and injecting blue dye around the tumor, finding a couple lymph nodes. As long as those are clear, we prove that we don't have to take any more out. That's a huge boon. We're still researching components of it, but this is truly the standard of care, and it has saved a lot of misery, pain, numbness, arm swelling, which is lymphedema, and arm range of motion. You go back to what Halstead did and realize all those patients were debilitated. We just don't have that problem now. They're early cancers and they're not involving lymph nodes, but we have to prove it still. So that's the sentinel lymph node biopsy. We started researching that in 1998 and became standard of care within 5 years. So that's surgery in a nutshell. Radiation, good and bad of radiation, a fascinating history. You may all know Madame Curie. She was Polish originally. She developed the theory of radioactivity and discovered two elements: polonium, she named after her home country, and radium, which is she was able to boggle the electrons and realize it is a whole new element. And they didn't know what to do with it at first, but they realized how powerful it was. She was the first woman in history to win a Nobel Prize. And she was the only person at the time to win, and still now I think one or more person has won a Nobel Prize in two categories. So she won it in physics with her husband and won it in chemistry by herself. And look at her family legacy. Her daughter also won one in physics, and her son-in-law won a Nobel Prize, won the Peace Prize. So she got two of them. Her husband had one, her daughter had one, and son-in-law had one. So it's pretty impressive. I think they had bragging rights. Unfortunately, she died of aplastic anemia, which is when your bone marrow loses, it gets scarred in because of radiation exposure. So she died of a disease related to her invention or her discovery of radioactivity, unfortunately, but she made a massive difference. So discovered in 1895, they realized it produced skin burns. So they said, well, let's try this for unwanted hair. We'll try it for acne. Why not for lupus? Why not for epilepsy? They had no idea. 1900, it was first used for cancer, but they didn't know what the tolerance levels were, what areas would tolerate it, what parts of the body would do well, until 50 years later. And it was still after that, when it was used for Hodgkin's disease, they realized, it can cause breast cancer when we give it to young girls with Hodgkin's disease. And we realized also that it can cause heart disease. And it was 1986 first published it was an interesting study. They looked at patients that had right-sided breast cancer versus left-sided breast cancer. They realized the patients with left-sided breast cancer died earlier. They didn't die of breast cancer, they died of heart disease. They realized the radiation, as it was given then, went to the heart and burned the coronary arteries, and they died of coronary artery disease. So radiation is done completely differently now because of that. But again, that's the evolution of care. We don't know what side of the unintended consequences, and these truly happened with radiation as well. Well, we use it for radiation for prevention of recurrence on the chest wall. So if patients have lymph nodes involved at time of diagnosis, they get radiation, even with a mastectomy. And if there's a recurrence, we use it. We can't use radiation more than one time, though. The body will never forget the radiation that's received, so you have to make sure it's appropriate the first time. But it has been a real benefit, although it does have a few side effects to it. It is a benefit to most patients, keeping it from coming back on that chest wall or in the area for breast cancer. This is one of the first ads for radiation. I thought this would be good. It's called a radiation emanation activator. Well, they had radioactivity in a water crock, and it was good for you. It's a revigorator. So if you really want to feel better, just forget the caffeine, just drink radioactivity. So I think we've come a long way since that time. Instead of irradiating the whole breast, we can do partial breast radiation called a mammocyte. We have proof of that we do that some now. We really backed off during COVID. Not every patient is a good candidate for it. If you get breast cancer, where is it going to recur in the breast? 95%, right around that same area. So you just treat that area. You don't affect the whole breast, and it works very well. It's a 1 week course, so it works well. The next step is, what about intraoperative radiation? The good and bad, we don't have it available here. Not that many places do. It's still a work in progress. but it makes good sense. You take the cancer out, you give radiation while they're asleep, and you're done. Problem is you don't really know what you have. Oftentimes the margins are involved. It definitely causes some scarring. So it's something that is a work in progress, but it is improving. So radiation is still standard in many cases. We're now realizing that some patients don't need radiation. So we're trying to realize which patients over 70 with breast conservation, it's called choosing wisely. Maybe they don't need radiation if it's a small tumor, if it's a lazy tumor. So we're trying to avoid treatment that really are not necessarily going to help. So look at the recent data. It's been interesting to see. Been here long enough that we see, okay, lumpectomy is doing great, but now we realize, sorry, let me go back one, that lumpectomies are decreasing again. So this is another hospital review. These are lumpectomies. We're cruising 1994, 60, 70%, and then it starts backing off. And these are mastectomies, the lower line, the yellow line, 40%, 30%, because lumpectomy is taking over, and all of a sudden it's creeping up. That's only in 2006, and it has changed. There are many times that mastectomy is more common surgery than lumpectomy. Well, why is that? Well, genetics has made a huge difference. MRIs have made a huge difference, and patient preference. When I was up at Brown, we did a study looking at older women versus older versus younger women. Younger women had more chance of cancer coming back in the breast. We didn't know why, but now we know it's because of genetics. And also MRI, mammogram's is not always that helpful on a younger patient, so MRI helps. Does MRI help every patient in the workup? No. The problem with MRI is it shows a lot of things that are benign. MRI scan before surgery, unfortunately, is never proven to help survival. It's never proven to improve a chance of recurrence. It has proven to increase the incidence of bilateral mastectomies. I've seen it find cancers for sure, and in the appropriate patient, it is appropriate to get an MRI scan, but we have to be judicious. A young patient with a lobular cancer whose mammogram is very difficult, absolutely, but it can cause problems and really delay treatment. So MRI is a good discussion. In the younger patients, typically, if it's a patient in their 30s, she has young children, has a family history of breast cancer, she's going to want bilateral mastectomy, not just for the prevention method, but because our surgical options are much better than they used to be. We've been doing nipple sparing mastectomies. This is where we make the incision under the breast and we take all the breast tissue out from that incision, leaving the nipple. And anymore, we don't even make an incision in the underarm to find that sentinel lymph node. And so this is under the breast. This is the shoulder up to the right. And it works very well. We have data proving that the risk of it coming back in the breast is no greater than if you take the nipple. So the cosmetic result is great. It's not for everybody and it's not for every situation, but it has sure helped a lot of patients both in prevention and also treatment of breast cancer. This is what it looks like. It's sort of gory, but this is the incision. What I do is dissect this. The black mark in the middle is where the blue dye was injected. And we make thin margins. You can see the blood supply in here. We take it all the way to the collarbone, and this is the muscle underneath. And it is a tour de force to get in there. It takes about an hour and a half to do that on both sides, or probably an hour on one side. And then the reconstruction surgeon would come in later. But it's a beautiful result with very limited problems. There are problems. This is not mine. This is a disclaimer. This was a patient that I had heard about, and I asked the plastic surgeon for a picture. You can get nipple loss. You can get skin loss. This ended up, this poor lady, I really think it's probably because she had a previous midline, an incision across her sternum and lost some blood supply to her breast that comes off these vessels near the breastbone. And she needed called a free flap later to get the results. So we always have to remember anything we do has side effects and has potential risks. So the patients have to know that as well. Nipple sparing mastectomies. Remember the implants have always been the standard. Years ago, patients would get what's called the tram flap. That's taking the skin and the fat and the muscle from the belly and giving you a tummy tuck and also giving you more breast tissue, but you've lost your abdominal musculature and it's hard to do sit-ups. Now they do what's called free flaps from that same area, not taking the muscle. And they can also do free flaps from the gracilis muscle underneath the leg, and tissue from the buttock area. So they're all tour de forces. They're all tough surgeries. And remember, they're all based on blood supply that you hook together with microscopes, and they are long surgeries. But they're very good results, and they're being used routinely now in appropriate settings in very motivated patients. So that's local therapy of the breast in a nutshell. I'm going to go through systemic therapy, which is chemotherapy, tamoxifen. You've heard of Herceptin. And I just want to go through the newer therapies, and then we'll be closing to wrap it up. But this chemotherapy really started being used in breast cancer routinely in 1975. How did we get started? It was a great history of chemotherapy. It started with mustard gas used by the German troops in World War I. If you look at those, the French and the Germans were 100 yards apart. Germany invented mustard gas. They just pour across the lines, and it was a miserable death. And one of the causes was bone marrow failure. The mustard itself would just kill the bone marrow, and you'd lose all your blood cells and you'd die. It was so terrible, it was banned by the Geneva Protocol. World War II started, and the Americans and the other countries were worried about the Germans again. And so the government asked two pharmacologists, Goodman and Gilman at Yale, and said, let's see if we need somehow to find out how to prevent further problems from that, from the mustard gas. And so they started looking at mustard gas, and they tried using it against lymphoma. Because why is that? Because lymphoma is an overgrowth of the cells from your bone marrow. They said, well, if we give a lot of it, we'll kill them. If we give a little bit of it, maybe we can kill some of these cells that are overgrowing in the bone marrow. And it worked. There was nitrogen mustard was used for a while. And then after that was, I want to go through Dr. Farber, because he was the fascinating next step in chemotherapy. He was the first one to really prove benefit of chemotherapy with aminopterin, which is one of the, it's a sister drug of methotrexate, which we still use. So this is Sidney Farber. Sidney Farber was from Boston area. He trained in Heidelberg and then Freiburg in Germany and then Harvard. Well, why is that? Well, he was the 12th out of 13 kids in his family. He was Jewish. And at the time, they were not going to allow any Jews in their medical schools unless they proved themselves first. So many had to go to Europe first, prove their worth, and then come back to this country for training. And so he was the first full-time pathologist at the Children's Hospital in Boston. And he said, let's look at the worst diagnosis. And what was the worst? It was childhood leukemia. These poor kids died within 12 months of their diagnosis, and it was just miserable because they lost all their cells, they would bleed to death, and it was just misery. And why did he use that? Because it could be tracked. He could follow it, and very quickly you'll know whether you're benefiting the patients or not. Well, he knew folic acid, which is one of our vitamins, had something to do with that. So he said, let's try folic acid. That was before clinical trials, before there was informed consent. They asked the parents, can we try it? And they'd say, well, and why not? We have no hopes otherwise. These poor kids died very quickly. And he realized, well, obviously folate doesn't work. Let's try an anti-folate, which is, again, methotrexate component. It blocked the chemical reaction needed for DNA. It blocked the overgrowth of these cells, and it proved to be effective in helping these children with leukemia. Their white blood cells dropped and improved. It was not an effective long-term cure, but it was the first big move. He presented this at the national meetings. This is a pathologist, and he's Jewish. They laughed at him. They said he was absolutely wrong, but he proved he was right. No one else was able to prove anything. They didn't believe it at first, but he was right. So more power to him. This is a picture of him in his lab. He's back here smoking his cigarette. His assistant's doing all the work, but he was in the basement of the hospital. They didn't give him even a reasonable office, but he did it. And the exciting thing was that he did it. And he said that it is, this is a quote from him, but you've heard of Dana-Farber. It is named after the philanthropist, but Dr. Farber, it is a huge, beautiful, one of the top medical centers in the country, because he had the guts and the fortitude to follow with something he really believed would help patients. So was really a great transition. We look at the Chemotherapy, anthracyclines, you've heard doxorubicin or adriamycin, the red devil. 1970s, we started using that. You throw in Gemzar, you throw in Taxol, Taxotere, 1990s, you started using that. Xeloda, which is capecitabine, Abraxane, which is nab-paclitaxel in the 2000s. Carboplatin, cisplatin for BRCA1 and 2, they realized that was going to be effective. And these new targeted therapies. So as we get closer to today, 2018, a lot of changes, a whole different landscape out there, many options that we never believed would have happened before. One of the big benefits of chemotherapy, as far as knowing whether it works or not, is giving chemotherapy up front, called neoadjuvant. That tells you whether it's working or not. If you do surgery first, then do chemo, you have no idea whether it's making any difference. So definitely with inoperable disease, inflammatory or very advanced breast cancer, if the patient desires lumpectomy, but it's too big, you give chemotherapy first. Or if they're unfit for surgery, you give chemotherapy. So it has been very helpful, but it's wonderful for research because we're able to see not survival, but response rates. And so you do the treatment, you do the surgery, they get a complete response. Tremendous. So we know we're onto something. And we can look at the different agents, and that's how we've gone from one step of treatment to the next. Lobular subtypes, your lobular cancer, slow growing ones, it's lazy. It's not going to respond to aggressive chemotherapy. It will just sit there and slowly get better, but you'll not know the difference. Early stage breast cancer, stage 1, you may not need chemotherapy at all, so you don't need upfront therapy. These are national standards that we've come to. It's a great addition, but not every patient needs chemotherapy upfront. Hormone therapy has been fascinating history here. So done with chemo for the moment. The hormones for women, as you know, they come from the ovaries. The ovaries are stimulated from the adrenal glands. Adrenal glands are stimulated from the pituitary gland. So it's all a big axis that tells us. So in 1870, it was Dr. Beatson, Thomas Beatson, realized that patients that were given estrogen, their cancers would grow faster. And he had the philosophy, he had no idea what they were doing. They said, we know the estrogens are related to the ovaries. Let's take the ovaries out. Lo and behold, in a certain number of patients, they would never know who, the tumor shrunk. It was phenomenal. And then they said, okay, well, on all these young patients, we're going to try to take their ovaries out. And it worked. It shrunk, but it wasn't a long-term cure. So actually, there are patients, they took the ovaries out, it shrunk, started growing back. Then they take the adrenal glands out, and they'd shrink again, and they grow back. Then they take the pituitary out. It was just a horrendous event, as you can imagine. Again, this is back when they were doing radical surgeries. It was working before they really knew what was working. 1970s, they discovered Tamoxifen and started using it because it was a sister drug to estrogen. It competitively blocked estrogen. They really didn't know on whom it would work. It wasn't until the 1980s that they had estrogen and progesterone receptor status. And we were able to know that, yes, this patient will benefit from hormone therapy. And the time frame, Tamoxifen in the 1970s, anastrozole, which is standard now in 1995, letrozole, exemestane, those are the three we use. Those are sister drugs. The anti-estrogens we use for postmenopausal patients, because we realized tamoxifen is bad long-term for postmenopausal. It's all we've had, but we knew blood clots, uterus cancer were high risk. So postmenopausal, we use those three otherwise. Newer agents for metastatic disease and advanced disease, fulvestrant or everolimus, they're both, it's Afinitor and Faslodex, things we've heard about, but we're dealing with the 2010s. This is a fast change, 2010, 2012, these were initiated and we're using them standardly now. So hormone therapy is tremendous. We know who to use it on, but we don't know who needs that and chemotherapy until more recently. You may have heard of Oncotype DX testing. Oncotype DX testing is a genomic test, not a genetic test. Genetic test looks at the woman at risk for genetics. Genomic test looks at the genes of the cancer itself. Based on research trials we've been through, do they need chemotherapy beyond hormone therapy? So that's been, it's been a tremendous boon because we have great data. So you look at patients, they end up with this test. You're going to have a recurrence score, meaning at 9 years, your chance of it coming back in the rest of your body is low or is it high. These tumors can look exactly alike. They can both be, they're all hormone sensitive and they look alike, but the 22 genes they look at will tell us, in fact, that some of these cancers are very low risk. Look at the green line. If they're treated with anti-estrogen therapy, they're going to do great, greater than 90% survival. Boy, the same look of the cancer, but different genes ends up being high risk, and you're down to the 60% survival without chemotherapy. The red liners need chemotherapy, and this has allowed us to know which patients need chemotherapy rather than just guessing. So you're healthy, you're young, let's do chemotherapy. We know which ones don't need it. So it's been a tremendous boon when not to use therapy. Again, a benefit of avoiding therapy that's unnecessary. So we've talked about systemic therapy using chemotherapy and hormone therapy. Targeted therapy is where we are today, much more so than ever. Targeted therapies are meaning they're man-made. They're monoclonal antibodies, means they're part human, part mouse, made in the laboratory, and they activate the immune system. A lot of these you can't understand how they got their names, but UMAB means they're part murine, part mouse, part human. And so trastuzumab, which is Herceptin, all those, UMAB means it's a human monoclonal antibody targeting the cancer cells. Not every cancer benefits, only if you have those targets. Look at Herceptin. What a great drug. It's for HER2 amplified tumors. If you look at the cancer cell surface are these little bubbles, and the HER2 are these little things that cross it and help amplify, help this cancer grow and help it metastasize. You give Herceptin and it blocks it. If you don't have a lot of the HER2, a lot of these proteins on your cell, you don't need the Herceptin. It doesn't help. But if you have a lot of these HER2, if you're amplified in that gene, having more of those proteins, it makes a world of difference. Well, how much difference does it make? Well, this is how you'll see how fast it's changed. So we started phase 1 trials in 1992 saying, we know what this is. We know these HER2 receptors. We've got this drug that might block it. Let's see if it does any good. And phase 1 means you're just seeing what kind of side effects the drug causes. Phase 2, 1 year later, they said, let's see if it makes a difference. Phase 3, we're going to compare women getting it and not getting it. And 3 years later, it was cleared by the FDA, an amazingly fast development. Why is that? Because if you look at survival with HER2 amplified cancers, look at the red line. If you have HER2 amplification, a lot of that HER2 on your cell, and you don't get Herceptin, your survival is down to 75, 80%. If you have HER2 non-amplified, which is better, safer, your survival is good. And your survival, if you are HER2 amplified and you get the Herceptin, it's as good as if you don't have HER2 amplification at all. So your survival, if you have HER2 amplification, we know it's bad. Your survival's just dropped 20%. But if you get Herceptin, you're back right up there with everybody else. When they first showed these slides at our national conferences, everybody's jaws dropped. We've never seen a drug like that before. So Herceptin is a tremendous addition to what we do. The next step is immune therapy. It's just another variant of targeted therapy. This came into the forefront with Jimmy Carter, who's still kicking. He was announced in 2015 that he had metastatic disease in the liver and in the brain. I heard that he was going to die. They treated with surgery, with radiation, and they treated him with Keytruda, which is immune therapy. 6 months later, 5 months later, he says he's cured. Didn't believe him. He's still cured. Realize that this stuff has power. And so it's immune therapy, and we're using it now more even with breast cancer. This was one of the first drugs in multiple drugs, all these different drugs that we're using now, trying out. And this brought the Nobel Prize in Medicine to 2 doctors, James Allison and MD Anderson. They realized that there's a protein. If you think about the immune system, we can fight infection well because our immune system says, this is a bug, we need to kill it. But cancer lives under the radar. It has the ability to sneak in there and not be identified as foreign. So what the checkpoint theory is that let's release the brake. Let's get the immune cells working again. And so it can attack the cancer cell, realize that the cancer cell is foreign. So that's what the checkpoint theory is. And that's what we're using now. That's all the new data. It's hard to explain. I've got a visual that will hopefully help. But this is Sherlock Holmes. That in solving a problem of this sort, the grand thing is to be able to reason backwards, meaning the immune system is the problem because these cancers live below the immune intelligence. It just grows, and we think it's part of us. We need to go back and figure out how to make that cancer, put a flag on there so we can kill it. This is, yeah, that's okay. Anyway, this is huge. So this was all these trials, the different types of immune therapy, PD-L1, PD-1, that's the ones we're talking about, vaccine therapies, T-cell, these are all coming. These are going to be in the future. Right now, this was 2 years ago, and we've changed. None of these were approved. We now are getting approvals here. Just wanted to give you a real-time look at things. This is the research we've done. This is, okay, you give patients the chemo plus this. This is the UMAB, right? This is the type of therapy that you add to chemotherapy for triple-negative breast cancer. We know it's a tough one to bite. So somehow let's try to find some targeted therapy for it. Therapy after surgery called adjuvant, and metastatic means these patients have identifiable, measurable disease in their liver or lungs. Let's give it a try with the Pembro, which is the drug we're talking about. And how is it done? This is the last few years. We're talking very quick research. Lo and behold, at the big meeting, the ASCO meeting, Keytruda, pembrolizumab, which is Keytruda UMAB, it's a human monoclonal antibody, it reduced the risk of progression or death by 35% when added to chemotherapy rather than chemo alone in metastatic triple-negative breast cancer. Huge. So we're on the way to curing these patients. So this is really the immune therapy, the targeted therapy is our next step. This is how it works. So if you have an immune cell, this is a lit up immune cell on the bottom, this is an ugly tumor cell on top, they touch each other and it said when functioning normally, the T cells, which is the lymphocyte, the same things that fight the bacteria and viral infections, they're activated and they shoot out the poison and they kill the tumor like they kill a bacteria. What the tumors were smart enough to do, they can evade the immune system through these PD-1, PD-L1. Those are just pathways that what the tumor has. These are receptors. These are the PD-1 receptors, look like golf tees, but they're the ones that figure out whether you're foreign or not, a friend or foe. And the tumor has figured out how to put a block in there and says, no, we're friends. Look, we don't invade us. And it keeps the immune system from fighting it. But what these immune agents, the Keytruda does, it blocks that so that the tumor, the T cell, the lymphocyte is again activated and it will kill the tumor. But they have to be patients that have on their tumors, these PD-L1 or PD-1, all these different ligands. So not every patient will have these. You have to find the right patients and it works tremendously. So this is where we're headed. So this is from a couple of years ago. The promise of immunotherapy is realized as the fourth method of cancer therapy, meaning we have surgery, we have chemotherapy, we have radiation, and now we have immune therapy. And it's landed on the doorstep to join the list of therapies that put the Halstead hypothesis, meaning you kill the cancer by taking off the breast, and mastectomy into the rearview mirror. And that was 2 years ago. And it's continued to really change dramatically since that time. You look at survival, this is going only to 2005. Breast is in the pink. The breast cancer survival has improved. Mortality rate per 100,000 women was 35%. Now we're getting down to, 35 per 100,000 women. Now we're down to 20 per 100,000 women, making great strides. This is an older slide. So overall, we're making great strides with survival of breast cancer. Still things we're having to work on. One of those is the variance between African Americans and white. Part of this is more Black patients, more African American women have triple negative breast cancer. And that's where this Keytruda and these agents are going to make a difference. But still, part of it is disparities of care. there is a difference, and we're fighting that. And this is something we're watching very closely. We want to make this equal. So again, very fitting today for this just came out where we need to make sure that the minorities, especially the impoverished minorities, get as good a care as anybody does. So it's both the management of the cancer itself, as well as the uniqueness of the cancer that the African Americans have. Finally, I'm going to pivot to survivorship. Just a brief couple slides. This was a comment from a friend. He said, the transition from patient to person was more difficult than chemotherapy. That's pretty profound. And it's nothing, when I came into practice, we really didn't think as much. Lynn Erdman did, and I think a lot of the cancer programs that women were heading understood that. That's why navigators came into existence. But it's so hard on the person. We're treating cancer, sure, but we have to treat the cancer patient. So one of the big things is survivorship. It started in 1996, realizing you have to survive. This is not just making it through the cancer and you're done. No, it is much more than that. And now you look at survivorship, it's a big deal, because look at the number of patients that are survivors. It's tremendous. Look at 2020 is just after the graph, middle of the graph, and it's only going to increase. So there's a lot of patients surviving cancer. It should be more than survivorship. It should be thriving. And that's what the goal is of the programs nationally. We are required now to have survivorship care plans for everybody. And that is a huge change. Again, evolution of care. This is not treating the cancer, but treating the patient. And it is an exciting change that we are compelled, we're forced by the national organizations to have these plans for women, so they have an understanding moving forward what to do, and not to be dragging that ball and chain without any help moving forward. The next thing is integrative health, integrative medicine for breast cancer. Who knew? 20 years ago, we had no idea. We thought it was hooey. But both Atrium and Novant have integrative medicine programs, and it's huge, and it will only get better as we started opening our cancer center at the main campus. Integrative health is right there, right on the same floor that we'll be. So it's an exciting transition that, again, is going to allow patients to thrive as they work through this. The advocacy, I'll go through this briefly, but I thought that was fascinating that early 1950s, the New York Times refused to publish an ad for breast cancer support group, stating that it would not print the words breast or cancer. So from that came Reach to Recovery. She was so mad about that she started this Reach to Recovery program. 1962, the American Cancer Society embraced it. Local supports groups started. Nancy Brinker, a sister of Susan Komen, started the Susan B. Komen Foundation. She when I came to town, we brought her in, Nancy Brinker, in 1995. She's wonderful. And almost $1 billion raised, made a huge difference with research and care. National Alliance of Breast Cancer Organizations, again, Rose Kushner, she was so offended by how she was treated that she was going to make a change. And she did. And she helped start the first Breast Cancer Awareness Month. Breast Cancer Coalition, increasing research funding, increasing cancer care for the underdeveloped, increasing activism and decision-making. Women are taking charge of that. And again, evolution of breast cancer care, this is a huge page on that. So I just wanted to acknowledge that. Where we are today. This is from the Komen Foundation. This is, look at rates per 100,000 women. I'm constantly asked, are rates going up? You look at this, 1992 to now, it is absolutely stable. We've not increasing the rates of breast cancer incidence in this country, but as I mentioned on the previous slide, rates of mortality, which is the dark green on the bottom, 35 women per 100,000 died. Now we're down to 20, and it will only get better from there. So in the 5-year relative survival is 90%, only going up from there. So because we're finding patients earlier, getting mammograms, we have better treatments. So markedly improving. Okay, last slide. This was by George Sledge. He is one of my heroes. He was at Indiana and now is at Stanford. A great thinker. He's the one who brought in the Taxol, and he just is a great thinker. He said, over the past decade, we've had more than one new cancer drug approved in the treatment of breast cancer per year. That's huge. All we had in the past was adriamycin. We had Cytoxan. Years and years, but one new agent per year is an amazing change. And what he's saying in the future, all patients will undergo panel testing meaning they will go through genetic testing for any cancer patient with any cancer. We're going to figure out the genetics of this, and patients will be more and more will understand why they're getting the pathology based on genetics. And all patients will undergo next generation sequencing. Think of that like the Oncotype DX. We're going to send the cancers. We'll think of it more like, what antibiotics are these infections sensitive to? We'll be able to sequence these cancers, which have the different ligands, which have these proteins on the surface, and therefore which targeting can we use? What targeted therapies can we use to target? So we're going to know this in the future. And then he said, I'm glad he said this, cognitive genomic intelligence and artificial intelligence will improve the interpretation of these tests, because it's all beyond me, to be honest. And I'm glad not to be a medical oncologist to have to pronounce all these new drugs, but it is moving. It is more exciting now than it ever has been, and it's more complicated for sure. So this is a comment by Isaac Newton, and I feel this every day, that we owe a great appreciation to the physicians that have been involved, but also the patients that have allowed themselves to be part of clinical trials. They've been very brave, and they are survivors regardless. So I appreciate your time. It's been over an hour. I apologize for that, but I'm more than happy to answer any questions.
Thank you, Dr. Turk. That is the best overview of the history of breast cancer I have ever heard. It was fascinating.
Well, thank you.
I am looking in our chat session right now, and I think everybody was listening so intently they didn't write down any questions. So I'm gonna open it up. If you want to just unmute yourself and ask a question, that might be the most efficient way to do it at this point. So, or if you'd like to just say hello to Dr. Turk, we'll do that for a few minutes. So I'm just going to ask everybody to just, hopefully one at a time, if you've got something to say, just go ahead and unmute yourself.
And there's no copays, right, for this?
So, Dr. Turk, this is Frances Smith.
Yes.
I'm a new patient of yours, and this was a wonderful session. I've learned a whole lot. One of the things I wanted to ask is, so testing for BRCA1 and 2 and Oncotype, why does that not happen until surgery, or does it happen before surgery?
So yeah, two different things. The BRCA testing is looking at the patient. And so new patients that come in, I ask myself two questions. Do they need genetic testing? And do they need an MRI scan? So the genetic testing, we would sure want to know before surgery, because if you are BRCA BRCA positive, we may think being more aggressive, right? If you're going to have a 50-70% chance of getting another breast cancer down the road, you may need to know the option of taking both breasts off. Not that you have to, but I would want to know that ahead of time. So a good question about the Oncotype testing. Oncotype patients, they have to be hormone sensitive, which we know that beforehand. They have to be HER2 non-amplified. Remember the Herceptin data. If you are sensitive to Herceptin, well, you're going to have to get chemo. And so you're hormone sensitive, HER2 non-amplified. That's the definition of Oncotype. So what we learn with surgery is lymph node status. It's a little nuance, but if the lymph nodes are involved, we actually have another test we can send off called MammaPrint that does the same thing as Oncotype, but they're for lymph node positive patients. So,
Okay.
But during COVID, we actually did some. We can send it before any treatments, and sometimes we do. That's a little bit muddy science. We're not sure exactly what to do with it, but yeah, I think in the future, that's a very good point. We will do some of that more and more in the future, knowing ahead of time what we need.
Well, thank you. Thank you.
Who else has a question? Anybody else?
So research is the critical change. And right now, a lot of the research are all these targeted therapies. You say, well, why don't we do more of these? Why aren't everybody on targeted therapies? Well, you look at the price. It's profoundly expensive. It's hundreds of thousands of dollars per year. And it will get better with time, but it's not just the Keytruda, it is multiple drugs. Some of them don't work, some of them do, but the profound expense of the research has to come out with the cost of the drug.
So I had another question, and it's about research. So you hear a lot about breast cancer research, and I'm glad I hear a lot about it because that's what I have. But you don't hear so much about research for pancreatic or lung or other kind of cancers. I mean, not like you do for breast cancer. And maybe it's just because it's so visible. I don't know, but why is there so much research money in certain cancers?
Oh, good question. In my history of cancer talk, I talk about pancreas cancer. I used to do a lot of those surgeries, and it broke my heart. It was a disease that we still have yet to push out very far. We've yet to see any immune therapy make a difference. One of the big issues is money. Right, it is breast cancer is the gorilla in money making, which is not a bad thing. It's like NASA and Tang and all the things that NASA did. That spin-off of that was tremendous with all the other industries because all the money was put on NASA. Well, all these targeted therapies are also helping other things. Well, stomach cancer, we're using Herceptin for patients with stomach cancer that are HER2 amplified. So it is spinning off into the others. But the high visibility is with breast cancer. So I hope that answers the question right. Pancreas cancer, we have tried and we are struggling to find things that we have some better survival, but don't have anything, no home runs, unfortunately.
Mm-hmm. Anybody else have a question?
I have a quick question. So I had triple negative breast cancer and I also had ER positive breast cancer. I'm not afraid of the ER positive breast cancer because it's slow growing. I'm on letrozole. But the triple negative breast cancer, I am afraid of that. I am afraid of it coming back. And my question was, when I had my mastectomy, they did not, I guess, test that tumor to understand whether or not it had the PD-L2 or the PD-L1. And I was just curious if you, as a surgeon, see that changing in the future for triple negative breast cancer patients.
Well, it's not available right now as adjuvant therapy, meaning treatment after surgery, but it is absolutely there. As I said, that was what the ASCO, American Society of Clinical Oncology, this year, they came out and said survival is profoundly different with the Keytruda on those that are, as you said, PD-1 or PD-2 positive. So metastatic patients always get tested. And that's what Dr. Sledge mentioned. He said all patients will get all that worked out initially on the first blush, like you were saying. So the way we know things benefit us is you start with a metastatic patient. If survival's better, then we put it into the adjuvant, into the patients, because that we need to see we call a statistically significant difference. And you can see that fairly quickly with metastatic cancer. So it is coming, and God forbid you'd ever have it back. That would be absolutely an option. So it is, again, the whole landscape will change along your lines. As you said, Dr. Sledge said, yes, in the future, your tumor upon diagnosis will get all that identified.
Okay.
Okay, I do have some questions in the chat now, or some comments. Yeah. Dina Richards wanted to share that she thought it was excellent information. Kathy Goodman says, love you, Dr. Turk. Your work on my left lumpectomy still gets compliments from my doctors and the mammography technicians. I had Herceptin 13 years ago and am doing well. And let's just see here. Ann Nelson, Dr. Turk, this has been so informative. Thank you. 9 years ago, last August, you started my journey and have been my hero ever since. I was thankful to be given the option to consider internal mammocyte radiation, which was between year, just a second here, which was between year 8 and 9 of it. And then Kristen, to everyone, says thank you so much for the informative session. My Aunt Linda, your patient, Linda Helixson, told me about this Zoom session, and I'm so glad she did. I'm about to start chemo for my breast cancer, and this was interesting and informative. Thank you. And Kathy wants to know, will Herceptin be replaced by newer drugs?
Interesting. That's a good question. So we have a second drug, and some of you may know, it's called Perjeta or pertuzumab, that if it's lymph node positive going in before surgery, you don't just do Herceptin, you add the Perjeta. And we've realized after surgery, adding it improves survival and recurrence by 3%. It's not a big difference, but it is a difference. And now there's a new agent called Kadcyla, which if you get Herceptin and Perjeta, which is pertuzumab, and another UMAB drug together, those are the anti-HER2. If you still have persistent disease, if it's somewhat resistant to it, you do better if you switch over to the Kadcyla, which is another type of Herceptin-based therapy. This is we're slowly inching toward more and more of a cure, but it's stepwise.
Shatrice wanted to say thank you, Dr. Turk, for taking excellent care of my Aunt Linda. My name is Jennifer, listening to support Linda and my sister, Kristen. God bless and thank you again. And Karen Wharton said her DEEP flap was a huge success and one tea time you are away from. I hope you understand that.
Yeah, I don't play golf anymore anyway, so we're good.
Okay, Ann Nelson, the end of hers was the mammocyte was 8 to 9 of a 10-year study. She's forever grateful for your care throughout that time in 2011 and 2012 during the lumpectomy and then the double mastectomy in 2012. I sing your praises to all new survivors. And Dina Richards says hello, that you were her surgeon as well. And okay, I think I've gotten through everything.
Well, good. Well, thank you. It makes me blush, and I'm very humbled by everyone there. And it was fun putting this together. It was actually, I dread public events, but it was a lot more fun even presenting it, because to me, this is a good part of my life, and I appreciate sharing that with you and having you guys spend the time and listen and ask questions. And I appreciate. I don't. I do my work. God does the healing, and I do appreciate the thoughts and prayers.
Well, it was absolutely fascinating, and it was an honor to have you with us. And we look forward to hopefully having you with us again in the future. And thank you for what you do for all the breast cancer patients in our area.
Thank you.
Thank you, everyone. Have a good night.
Everyone have a good evening. Thank you so much for joining us.
Thank you.
Thank you. Good night.
Thank you.
Good night.
Thank you.
Leslie, can I ask one question? Did
Yes.
I understand you to say in the beginning that this will be replayed on your Carolina Breast Friends YouTube
channel? Yes, it will
Good.
take a couple of weeks probably for it to be uploaded, but the
Good.
entire recording will be on our YouTube channel.
Wonderful. I'm going to share that with a couple people I know. Thank you. Thank you.
Perfect. Thank you again, Dr. Turk.
You're welcome. Thank you. Have a good night. And we'll stay in touch. Leslie, we'll talk in a couple of days. Just want to catch up with you on this. So thank you for doing this. I putting a Zoom meeting together is not easy, but again, I thank you for all your patience.
Well, it was my pleasure. I look forward to meeting with you soon.
Good. Thank you.
Dr. Turk, do you
Yes.
still have that picture in your consulting room?
We do. That it's a picture of Jesus standing behind the surgeon. That I don't know if I told you where it came from. That came from my partner's wife, Dr. Fowler's wife. I took care of her. She had bilateral breast cancer about 15 years ago, and she put it up there for us.
I knew I was in the right place when I saw it.
Oh, that's very special. Thank you, Joyce.
It is. Thank you, Joyce.
Thank you.
All right.
Well, I don't think anybody wants to hang up because we're having such a good time, but
Well, thank you so much again. Have a good night.
okay.